Hi everyone, and very good evening to all of you. I hope that you're all fine and in the best of your health. So this is again a mega revision series, जहाँ पर we'll try to discuss all the questions of the INICET and AIMS. So what I've done is I've tried to put all the previous year questions right from 2019 onwards, and just don't take them as a questions. Okay, take them as a real time way to revise all the topics as such. And in case you have any difficulty anywhere, do let me know. Let's take the session in a way to revise most of the topics here. And the moment you have any discussion, or you want to ask me anything, just put it on the group also. I'll take those all discussion points as well here also. So yes, good evening to all of you, those who have joined me at this point of time. First of all, tell me, how is your preparation going on? Is there anything that you want me to cover today in a better way? So hi, yes, very good evening to all of you. I'll just put some books here. So guys, yes, very good evening to Vidhi, Fomo, Shefali, Chandrani, Elsa, Aditya, Supriya, Amartya, Devanand, Dopamine. Hi to all of you. तो स्टार्ट करते हैं जनरल पैथोलॉजी. देखो, anyone who has scored whatever rank in the NEET exam, do not worry about that. First of all, that was just a 3 hour session or 3.5 hour session that actually went maybe up and down. So INICET has given you one more opportunity. Do not stop where you have just reached. Try to ensure that you revise the complete thing now onwards also. And for that, there is nothing better than a previous year session that we're going to take today. And this session will be really very important for any of you who has just lost a bit of track, or someone who has not been able to revise well after the result got declared, or maybe after the exam got actually over. So guys, just to be in a positive state of mind, I just want you to focus here, be very interactive with me, and in case of any issue, do let me know directly so that I can solve your doubts in the real time here only. The session, I am very sure, would be available after live, but I'm not sure how many days it will be available for. So I would suggest all of you to just listen to me on the live session, and just ensure that you want to uh, listen to me very carefully, discussing every options here. So I have around 200, more than 200 slides, and in which I'll discuss around 200 questions also today, because I've taken a lot of other questions, which is very important from the NICT point of view also. So I'll just say a few things here. Sir, I did a lot of silly mistakes. Don't worry about it, Rahul. Don't worry, I'm with you. I think it's not a exam is not so near that we want to take the session in a very I'll say in a very uh, um, let's have some fun also in simple words. So that is what I'll just tell you right now. So pedigree, okay, I'll try to include that. Even though I don't have any question of pedigree today, but is this question enough for PYQ, or need to revisit PYQs again? I don't think there's any other need of doing the PYQs again. This session is really more than sufficient. One such session would be not be removed, right? I'm not sure about it. It may be removed, but it's therefore better you just watch it on real time also. So will we get a PDF? Yes, the PDF of the session will be available in my Telegram group after the session is over. Okay, so can we start here? So all of you who want to start right now, just give me a thumbs up. Please remember, it's a previous year questions. It is not a discussion of the entire pathology. I'll discuss entire pathology with the questions as and where they come into. Okay, but please remember, pathology as such will give you minimum of 25 questions in this year NICT for sure. There's no doubt about it. So listen to me carefully. Do interact to me in whatever possible way you can. Okay, chalo. So I'm starting with the November session of INICT 2022. Because most of the question of the set 1 and set 2 were very common. So I've taken a common type of questions from both of them and included as one of them. Chalo. So with a thumbs up here, I think we can very well start to this. Okay. So identify the instrument as shown here. So if you look at this instrument as was shown in last year's exam also, so this does not have any side shoe, and this is a bone marrow biopsy needle, right? So in a bone marrow biopsy needle, what comes to your mind? What should come to your mind is a Klima, Sala, Islam, or a Jamshedi. But when you look at these needles as such, you know, you have to look whether the image is showing you side screw or not. Now this image has no such side screw, and remember, when there's no such side screw, the only possible answer here is actually a yes, it should be a klima. So why it is not sala? Just look at the image here. Now look at this images. So bone marrow needle, it could be having a side screw here. So if you see a side screw, remember, S for side screw, S for sala. Okay, S for side screw, S for sala. Now look at this long needle and look at the handle and the cap here. Handle and the cap here. Now this is what is called as a Jamshedi. Okay, it's a Jamshedi Trifine biopsy needle. Jamshedi Trifine biopsy needle, and this does not have a side screw. So this actually does not have a side screw. It is referred to as a klima. Now what are the other question you can expect this year is the site of hematopoiesis. Remember, a site of hematopoiesis is always starts from the yolk sac at the third week. It then goes to the liver at around third month. From liver it goes to the bone marrow at fourth month, and that is where it remains throughout our life. Just remember, at birth it is only at the flat bones, and when we reach the adulthood, that sorry, in the birth time it is both in the flat bones and the long bones, but when we reach the adulthood it is only in the flat bones. And you all should remember the examples of flat bones. Now when we say bone marrow here, there was a one confusion. The bone marrow is where it starts. Okay, so at birth, when I'm saying at birth, so at birth also is bone marrow. Okay, so there is where it is starting here. Please remember, that's how you must remember, this is how it is starting here. Okay, chalo, let's move to the question number 2 here. So question 1, I think you all got the point. Identify the instrument shown here. It's a bone marrow biopsy needle, and there is a no side shoe, and hence it's a klima needle. Okay, you remember this is sala, it's a klima, and this long needle is a Jamshedi needle. Do not forget about the various site of bone marrow biopsy also. The biopsy site can be in a posterior superior iliac spine in case of adult, and in the tibia in case of child. Okay, however, if you want to choose one of them, the best answer obviously is the posterior superior iliac spine. If you want to choose as the sternum, the site will be second intercostal space, and the only thing that you should need in sternum is a side screw, that is sala needle. Okay, chalo. Islam is not used at all nowadays, so just forget about that. Chalo. A 24-year-old with a history of neck swelling on the right side with a thyroid which moves with degglutination. I think you got the point. It's a thyroid which moves with degglutination, and the excision biopsy was done. Okay, now look at this one. So in this one, what you're seeing is a papilla, right? These all are papillary projection. This like a papilla here. These all are like a papillary projections. So because this actually, it should be a case of round follicle like this. The follicle always round, and the cells are here, whereas inside the follicle there should be a pinkish area of colloid like this assay. This should be a normal follicle. However, please remember one thing: if this entire thing becomes like a assay papilla, is tarah se, okay, if it becomes like a papillary, and the cells here, they become like a orphan ani nuclei like this, that means they have a clear space inside them, it is referred to as a papillary cell carcinoma. Okay, it is therefore referred to as a papillary cell carcinoma. So now you'll ask me, sir, what is happening to the colloid between them? So colloid is often gone, and what is between them, inside them, is a vascular vessel area here, and therefore it is called as orphan ani nuclei having a papillary carcinoma. So देखो, why it is not follicular carcinoma? देखो, this is papillary. Please remember the basic concepts. It's a papillary carcinoma. Had this been a case of follicular carcinoma, you must have seen a clear-cut follicle only. But the only difference you will see in a follicular carcinoma, even though they will not give you an image of follicular carcinoma, but just remember, if they give you an image of follicular carcinoma, they'll first give you a capsule like this. Okay, there is a thyroid capsule, and the follicles should invade the capsule like this. Okay, but they should all look like a follicle only, and the follicle may or may not have colloid inside this like this. So it will become a follicular carcinoma. The follicular carcinoma, you have to prove there is an invasion, and to prove there is invasion, okay, to prove there is invasion, what you need to see to prove an invasion is you have to do a biopsy always. FNAC cannot prove that. Okay, so there's also a question you will always get this, that which technique is used to prove a follicular carcinoma over adenoma? It is biopsy. But FNAC can prove, that means FNAC or biopsy you can use for papillary carcinoma, but only biopsy can be used, BX the biopsy can be used for a case of follicular carcinoma. Not to forget some very important point that you should revise for the thyroid carcinoma. If you want to revise with me, just see this. So So a quick revision for thyroid carcinoma, all the important points that you should know, and those are these points. देखो, the most common thyroid carcinoma is a papillary carcinoma. Least common is anaplastic carcinoma. Okay, least malignant papillary. That means the best prognosis also is papillary carcinoma. Most malignant is anaplastic carcinoma. Okay, most common cancer after radiation therapy is papillary carcinoma. The cancer that develops in Hashimoto. This was the last years of NEET PG question is lymphoma. Okay, not papillary carcinoma, lymphoma. Cancer developing a long-standing follicle, thyroid gland goiter, is a follicular carcinoma, whereas anaplastic carcinoma is very rare there. Okay, so this is again one question which often students get confused into. A few other things that you should know. Type of thyroid carcinoma in men's syndrome is Mallory. Amyloid is seen with again Mallory. This was again a last year's INICET question. Sama body is seen with papillary carcinoma. And remember, the other causes of Sama bodies are papillary carcinoma, serous carcinoma of ovary, and meningioma. Orphan ani nuclei is seen in papillary carcinoma, and thyroid carcinoma with dystrophic calcification again in papillary carcinoma. कैसे याद रहेगा? Because ultimately the Sama body is nothing but a calcification. Therefore, this again is seen in the papillary carcinoma. Okay, C cell of thyroid is Mallory carcinoma, and when Mallory carcinoma is nothing but a men syndrome. कौन सा men? It is seen in men. बोलो कौन सा men? Men 2A also, men 2B also. Remember all of those? And what is the mutation seen in men 2A and 2B? बोलो mutation in men. Remember? Yes, it is red gene. Very good. 2B में you see red gene. And the thyroglossal cyst that you see here is papillary carcinoma, develops in a thyroglossal cyst. Chalo, anyway, this was a small revision of the cancer. Okay. Okay. Chalo. So these are all the questions that can be asked. Not to forget, there is nothing called a so-called Hurthal cell tumor. Hurthal cell often is seen in both papillary carcinoma, sometimes also in follicular carcinoma. But Hurthal cell is basically a hallmark finding of Hashimoto thyroiditis. So if you get a question on Hashimoto thyroiditis, so you must be able to identify what? देखो इसको. For a question on Hashimoto thyroiditis, you must be able to see huge number of lymphocytes, and these all are pinkish cell there. The pink cell is called as oxyphil or Hurthal cell change, and not to forget there is a germinal follicle also there. Okay, germinal follicle also there. ठीक है, ये clear हो गया? It is an autoimmune destruction of thyroid gland, and it happens because of anti-TPO body, and it is due to the T cell and B cell destruction of thyroid gland. Nothing more can be asked than this in the thyroid histology. Bus. Okay. Chalo. So this is how the thyroid gland look like, and you look, she is orphan Annie. Look at her eyes. Her eye do not have eyeballs, right? ऐसा eyeballs होना चाहिए ना? So she doesn't have eyeballs. Now because she doesn't have eyeballs, this nucleus looks like all these clear nucleus you see here. So because this papilla, the papilla contain the clear nuclei, and hence we call this papillary carcinoma. Okay, papillary carcinoma. ये clear हो गया? Papillary carcinoma. चलो. Okay, let's move to next question. A 56-year-old presented with fatigability and pain abdomen. Okay, the CBC count shows a 4,50,000 with eosinophilia and basophilia. अब बताओ, देखो, how to understand? First of all, in these question, always look at the age. ठीक है? So because it is a mid-age, I think you should not answer ALL there. ठीक है? Fatigue है और pain abdomen है. The CBC is showing you very high count. So when you see high count, what should come to your mind is leukemia. So what you should think is acute leukemia or chronic leukemia. If this would be a case of acute leukemia, suppose AML, this must show you blasts. Agreed? If it is a case of CLL, it should be asymptomatic, and it must not show eosinophilia and basophilia. It must show lymphocytosis. So because it's a case of eosinophilia and basophilia with such a high count, the answer is chronic myeloid leukemia. And yes, very well answered. It is a garden party appearance. ठीक है, बहुत अच्छा बोला आपने. It's a garden party appearance in a CML. So what question can you get? You can get a question like this. So this is a garden party appearance. So what you see in a garden party appearance is, देखो, these are all the RBCs, no doubt about it, right? So what will be asked, since it's a case of chronic myeloid leukemia and CML, देखो, in this case, this is a neutrophil, right? It's a neutrophil. This again is a neutrophil. These two are the band form. Now, how to identify a myelocyte? So if you asked what is a myelocyte, myelocyte will have a D-shaped nucleus. देखो, ये सब D-shaped nucleus है, देख रहे हो? These all are myelocytes. Okay, now whenever you see a myelocyte and then you see a nucleus getting cut inside, So if you see a nucleus getting cut inside, it becomes what? It becomes a metamyelocyte. Bolo sab log. This one and this one is what? It's a metamyelocyte. क्या दिख रहा है बोलो सब लोग? It's a metamyelocyte. अच्छा. Now how to identify a blast? बोलो बोलो blast. So blast is nothing but this is a blast, a round cell with a very large nucleus, a high NC ratio है ना? High NC ratio दिख रहा है ना? High NC ratio, large nucleus, large and less cytoplasm. Now this one is a blast form. So apart from this, what else you are seeing in this image is the basophil. This one is a basophil. So because it's a basophil, there is a myelocyte, metamyelocyte. Therefore, it's called as garden party appearance. Okay, garden party appearance. अच्छा, what else can you be asked? You can be asked what is the next step. अब ध्यान रखना, next step में बच्चे लोग इतना गलती करते हैं. देखो, if you get a question, please listen to me carefully. If you get a question on suppose acute leukemia, okay, and then the blast percentage, okay, is less than 20% in the peripheral smear. In that case, you have to do the next step, bone marrow aspiration or biopsy. Clear? But suppose the blast is more than 20%, in this case you will do flow cytometry. ये clear हो गया? अच्छा. Suppose you get a case of CLL, and CLL मतलब how do you get to know CLL? It is showing you lymphocytosis and smudge cell. So in that case, you do not do a bone marrow biopsy. In this case, the next step will be flow cytometry. ठीक है? In case of a history of CML, again, in CML, अगर you are finding a garden party appearance and you're asked the next step, in that case, you'll do a lab score. And lab score, you all know, should be low. अगर lab score low है, in that case, the next thing should be confirmed by doing a FISH. If FISH is not in the option, in that case, go with PCR. If not in the option, only then you can go with karyotyping. Bolo. Anything, any doubt here? Anyone having any doubt here? Anyone having any doubt here? बोलो इसको. Please interact to me. बोलो बोलो. ओके, जस्ट डोंट सिट आइडल. नहीं तो फिर क्या होगा, बाकी थॉट्स आएंगे आपके दिमाग में. क्या क्या थॉट्स आएंगे कि नीट में एग्जाम खराब हुआ, रिजल्ट खराब हुआ, अरे अब हम क्या करें, आई एम नॉट फीलिंग गुड, आई एम नॉट फीलिंग गुड अबाउट माई सेल्फ. यू ऑल आर हीरोज. Okay, you have given NEET, yaar. You're getting a good rank. Right now also can get a seat that will get you a good life. You just want to make your life better, right? And just to make your life better, we're trying to study more and more. Elsewise, all of you getting even 60 on rank can get a seat and you get a very good life out of yourself. We just want to make our life better. So feel good about yourself. Just feel confident, right? Just say that I'm confident. ठीक है ना, अपने आप को कॉन्फिडेंट फील तो करो. वंस यू फील कॉन्फिडेंट अबाउट योरसेल्फ, यू विल फील दैट इन योर स्टडीज आल्सो. व्हाट हैज हैपेंड. इंटरेक्ट टू मी यार. चलो, सो आई थिंक दिस वन इज क्लियर. लेक्चर बाजी भी बहुत हो गया. AML फिश कर सकते हैं, बट नेक्स्ट स्टेप नहीं आएगा ना बच्चे. हाँ, इसमें भी in all these steps you can also do fish, but fish is only for prognosis, not for diagnostic purpose, right? ठीक है, चलो. Which molecules help in the movement of leukocytosis across the endothelial cells? Okay, so how to revise this thing? I'll show you the image. देखो, so when you get a image like this is what you must remember. I'll just take it out from here and explain you there only. देखो, तो in this case, so how to revise this topic? देखो, the first step in cellular events, okay, the cellular events in inflammation, the first thing you should get is the step of margination. Next step क्या है? Rolling. Third step क्या है? Rolling. Okay, third step क्या है? Rolling. Sorry, addition. The fourth step is diapedesis. Fifth step is chemotaxis. And the sixth step is phagocytosis. And the next step is killing. Okay, so देखो, what are the MCQs asked? That for the purpose of rolling, what is the molecule on the endothelium? Answer is selectins. Okay, what is the molecule on the WBC? Sialyl Lewis X glycoprotein. Okay, Sialyl Lewis X glycoprotein. For the step of addition, okay, the step of addition. So addition के लिए क्या होना चाहिए? There should be ICAM and VCAM on the endothelium and integrins on the case of WBCs. Okay, now this was the question asked, right? This is a question being asked. क्या पूछ रहा है? Help in the leukocytosis movement across the endothelial cells. So answer is surely PCAM1. तो PCAM1 क्या करता है? PKM1 is involved as a CD31 and helps in transcytosis, or it helps in the movement across the endothelial cells. This movement is called as chemotaxis. So question क्या आएगा? What are the chemokines? Remember the chemokines में it is something to call someone. तो इधर इधर आओ है ना? तो C5A A से आओ and stand before me. Leukotriene before. Interleukin 8, okay, and apart from them the bacteria itself is a chemokine. Once it will reach here, it will engulf the bacteria. Once it engulfs it, तो क्या होगा? The bacteria will enter inside this and this will now start killing. So now there is a phagocytosis which involves 3 steps. पहला step क्या है? Recognition. For those who remember my classes, I tell you how to eat a samosa. First you go and identify the samosa, okay, पहला. The second one is to engulf it. And how to engulf it? First by adding chutney. What is a chutney? It is opsonization. And what are the examples of opsonin? It is C3b, 4b, 5b, IgG, FC receptor of IgG, and fibrinogen. Okay, and fibrinogen. These all are those and there. Okay. So now the last step is killing, and the killing occurs by auxin dependent and the auxin independent mechanisms. ठीक है? This is all about the cellular events of inflammation. अगर क्वेश्चन आ रहा है E-selectin, it is help in rolling. देखो CD11A क्या है? 11A, 18, these all helps in addition surely. And addition के लिए you require what? ICAM, VCAM. For addition I remember ICAM, VCAM, and this involves with what? It involves with integrins. Do also revise in this topic what is LAD1, LAD2, सब कुछ revise करके जाना. Okay, don't forget that too. चलो, now here comes the basal type of breast carcinoma. Okay, basal type of breast carcinoma. What is this all about? देखो, what we do, I'll just show you something. देखो, देखो, so when you have the typical type of, sorry, yeah, sorry, so in case of IHC, this is how the IHC is put on a breast. Okay, so this is what you're seeing is a ER and PR. Remember, if you get an image on ER and PR, so ER and the PR, that is estrogen receptor and progesterone receptor, these IHC are always having a nuclear staining. Okay, nuclear staining. Whereas if you get an image on the HER2 new, they'll have a membrane staining. Okay, that is how you must identify the immunohistochemistry of the ER, PR and the HER2 new. अच्छा, HER2 new is also called as EGFR2. इतना ध्यान रखना चाहिए. अच्छा, now how is the classification done? It is called as a classification in which you look into the morphological classification. देखो, तो दो तरह classification होता है. One is morphological and what is molecular. What is morphological classification? उसको देख लो. In case of the morphological classification, the tumor of the breast is defined as either a non-specific type NST, that is NOS, or can be various other types. What are the other types of breast carcinoma? It can be lobular, Melry, metaloblastic, apocrine, cribriform, tubular, inflammatory, colloid, papillary, mucinous. इतना नहीं जानना है तो सर पढ़ क्यों रहे हो भाई? तुम्हारे खुशी के लिए पढ़ रहे हैं, इतना नहीं जानना होता है. बट व्हाट यू मस्ट नो, ध्यान से देखो, if you get a image on a Melry carcinoma, in a Melry carcinoma you'll get huge amount of lymphocytes. देखो, these all blue color cells. So all the blue color cells are huge amount of lymphocytes. So if you get huge amount of lymphocytes, it will become Melry carcinoma. ठीक है? So if you get a papilla like this papilla, it is called as micropapillary pattern. But ये सभी क्वेश्चन नहीं आता है. क्वेश्चन जो आता है वो देखो. One question has come on mucinous. This was 2 years back question on NEET PG. It's a mucinous carcinoma, image based, and what you must know is a indent file pattern in which you see the cells arranged one by one, one after other, and this seen in lobular carcinoma. ये क्या है? Mucinous. और ये क्या है? It is indent file pattern. Indent file pattern. अच्छा. अब what you must know in the molecular classification. देखो, if you get a ER positive, it is type 1. कैसे याद रखेंगे? ER positive, 1 positive, तो it is type 1. Also called as luminal type. क्या कहते हैं बच्चे इसको? luminal type. Type 2 is HER2 new positive. कैसे याद रहेगा? 2 is type 2. 2 is type 2. And if you get ER negative, PR negative and HER2 negative, all three negative, it is type 3 and hence it is basal type. It is basal type. Okay, so among them, the most common is luminal, the second most common is HER2/neu, and the third most common, the rare variety, is the luminal or the basal type. Luminal or the basal type. Okay, now also the question can be asked is, among these three, which has the best prognosis? So this first one, ये देख रहा पहला वाला, this first one has the best prognosis. Okay, and what you give as a treatment here, you give hormonal therapy here. Okay, because ERPR positive है. In the second one, what you give trastuzumab or Herceptin therapy. And the third one, you cannot give hormonal or the trastuzumab, you have to give chemotherapy. And once you do this, then you also have to resect that tumor of the breast. Depending upon the extent, you can do modified radical mastectomy or a complete mastectomy, including the resection of the lymph nodes also. But you have to remove the lymph nodes only when the sentinel lymph nodes are positive, else you do not have to remove the lymph node. That also has been asked question. सो इसका आंसर क्या होगा? सो बेसल टाइप इज ER नेगेटिव, PR नेगेटिव एंड HER2/neu नेगेटिव. अब याद रखना, वन क्या बोला? ER पॉजिटिव. टू क्या बोला? HER2/neu पॉजिटिव. और थ्री क्या बोला? ER नेगेटिव, PR नेगेटिव एंड द HER2/neu ऑल्सो नेगेटिव. HER2/neu ऑल्सो नेगेटिव. ठीक है, तो दीज आर द क्लासिफिकेशन ऑफ द ब्रेस्ट कार्सिनोमा. सो ऑल ऑफ यू फॉलोइंग मी? Bolo, are all of you following me? Sir, for HER2/neu positive trastuzumab, prognosis remains same. HER2/neu positive trastuzumab is always given. Prognosis of these, that second one is poor, not because trastuzumab is effective, but देखो, what happens is that type 2 is having a poor prognosis. Why? देखो, these both have poor prognosis, only this one has good prognosis. Now you might be asking why? Because this type 2 and type 3, they include poorly differentiated breast carcinoma. Okay, they include poorly differentiated breast carcinoma, and therefore type 2 and type 3, they both have poor prognosis. Clear? ठीक है, they both have poor prognosis. Why? Because they both actually have poorly differentiated breast carcinoma. ठीक है ना? अच्छा, फिश कब करते हैं उसके लिए क्वेश्चन आ रहा है, तो थोड़ा सा सब्र रखो. सब्र 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 सब्र. ओके, अगला क्वेश्चन. अ 10-year-old boy with hemoglobin of 7.6, MCV of 56, MCH of 22, ferritin of 150. ओके, नॉर्मल कितना लिखा हुआ है? 130 to 160, and leukocyte count of 7600, lymphocyte 65%, and neutrophil is around 30%. Okay, अब देखो, for a 10-year-old boy, पहले समझो, this one is anemia, no doubt about it. Okay, अब TLC count is normal and hence it excludes, there is no chronic disease. ठीक है, अब देखो, MCV is low, MCH is also low, ferritin is almost normal, or is almost normal. तो what do you exclude out of it? ठीक है, अब देखो क्या होता है. देखो, it cannot be sickle cell anemia because कोई symptom ही नहीं है ऐसा. Okay, now it cannot be a case of ACD because 10-year-old boy में, in a 10-year-old boy you do not expect ACD because of the TLC is also normal. TLC is also normal. You cannot expect the ACD also. अब क्वेश्चन ये है कि whether is thalassemia or it is iron deficiency anemia, because this type of question is very frequently there in a case of in INICET. I've seen this. Now, because the ferritin levels look normal, so I will not go in this case with a case of iron deficiency anemia. क्यों? Because ferritin levels should be low in case of IDA. So with this history, MCV low है, MCH low है, and a TLC also looks normal, it can go to a case of thalassemia. तो सर क्यों ऐसा कह रहे हो? Why not IDA? Because the ferritin levels given are normal. ठीक है, and hence it does not fit into the case of IDA also. So why it is not ACD? Because the TLC looks normal. So in this case, देखो, whenever such question will come, and this was asked 2 to 3 times in this year INICET also, एकदम ऐसी हिस्ट्री घुमाई फिराई थी, and therefore in that case it becomes a case of thalassemia also. It becomes a case of thalassemia also. देखो, in this case you cannot calculate Menzer index because Menzer index you will calculate only when you get a RBC count. समझ रहे हो? In this case you are not given a case of RBC count, इसलिए Menzer index will not help you here. Okay, सर डू वी नीड टू रिमेंबर द MCV MCH वैल्यूज? यार याद कर लो ना, क्यों टेंशन लेना है? वेरी सिंपल है ना. MCV इज 80 to 95. ओके, MCH obviously is 30 plus minus 3 और MCHC around is 32 plus minus 2. ओके ये फेंटिलीटर में आता है, ये पिकोग्राम में आता है और ये आता है ग्राम पर डीएल में आता है, ऑलमोस्ट लाइक द MCHC. सो आई थिंक देयरफॉर द आंसर शुड बी थैलासीमिया इन दिस केस. ओके अच्छा, now this question, maximum amplitude in a TEG image. देखो TEG was being asked for 2 to 3 times in the INICET and was also asked as an image based question in a case of NEET question, and this time they had asked what maximum amplitude in this case is seen. अब ध्यान से सुनना, देखो what is TEG. You take a plasma, okay, you take plasma of a patient and you allow it to clot. ठीक है, क्लियर हुआ? Now, once you allow it to clot, so once you allow it to clot, initially it will take some time to clot. Suppose this is a time 0 second. Okay, so it will take some time to start the clotting. ठीक है, suppose the clotting starts at this point. ठीक है, तो initially what it forms, the primary plug. The primary plug is the maximum amplitude here. This is what, it's a reaction time, or the time it takes for the clot to initiate is reaction time. Now this primary plug, it depends upon the amount of platelets, so maximum amplitude, it depends upon the platelets. Okay, now once the clot is formed, it slightly goes up as a secondary plug and then starts lysing like this, and then the clot starts lysing like this. Okay, so the secondary plug, it may be here, but then this is the lysis point, it's the lysis point. Now suppose, example samjho, suppose a clot has less maximum amplitude like this. ठीक है, it means the amount of platelets in that plasma is less. Suppose a clot is not lysing, it is like this. Okay, it's not lysing at all, it's taking more time to lyse. That means the lysis is not normal, that means the lysis is not normal. ठीक है, so just remember the identification of the image is important. अब एक बार इस इमेज को देखो, reaction time मतलब the time it takes for the clot to initiate. Okay, clot, it time it takes the clot to initiate. MA मतलब maximum amplitude. Okay, maximum amplitude, it depends upon the amount of platelets, amount of platelets. Okay, फिर देखो यहां पर लिखा हुआ है L/30. So obviously after attaining the maximum amplitude, it should lyse. So 30 मतलब, sorry, yeah, 30 मतलब that percentage lysis. Okay, percentage lysis at 30 minutes. So after 30 minutes, how much lysis has happened, whether it is here or here or it is here, after 30 minutes how much lysis has occurred is L/30. That's all you must know in case of TEG. The first part is coagulation and second part is fibrinolysis part, fibrinolysis part. ठीक है, चलो चलो नेक्स्ट क्वेश्चन, सेनाइल एट्रोफी इज ड्यू टू, बताओ. बोलो, सेनाइल एट्रोफी इज ड्यू टू. बोलो बोलो, सेनाइल एट्रोफी इज ड्यू टू. यस, देखो दिस इज ड्यू टू अ मल्टीपल इनफाक्ट. ओके, इट इज अ मल्टी infarct dementia. It's a multi-infarct dementia in atherosclerosis. Okay, it's a multi-infarct dementia in case of atherosclerosis, and therefore the answer is reduced blood supply. Now this is a type of atrophy, and what are the other question you can expect of atrophy is, what are the other types of atrophy? Remember, it is first of all, if you talk about physiological atrophy, so physiological atrophy is what it is. Bolo, physiological atrophy is only seen during embryogenesis. Okay, the pathological atrophy is like disuse atrophy, denervation atrophy. Okay, it can be ischemic atrophy. ठीक है, ischemic atrophy. और बताओ, it can be case of nutritional atrophy, it can be case of pressure atrophy, and as I mentioned above in this question, it can also be senile atrophy. All of these atrophy can be there. ठीक है, clear? चलो, this is all other types of atrophy you must know. And what is atrophy? Decrease in cell size or number or both. both of them can be also a case of atrophy. Chalo, the following is positive in case of Hodgkin lymphoma. Now, was a question asked last of NICT, and many students actually got confused here. एक बात समझो मेरी बात, बड़ा clear समझो. If the examiner is trying to ask you about Hodgkin lymphoma, so in that case, he's trying to ask you clearly that whether you know the difference between Hodgkin's and non-Hodgkin lymphoma. So whenever you get a case of CLPN oblique a case of so-called lymphoma, it must be very clearly understood that this could be either a case of Hodgkin's lymphoma or can be case of non-Hodgkin lymphoma. अब देखो, a non-Hodgkin lymphoma, it can be either a B type, it can be T type, or can be NK type. Okay, it can be a B type, it can be T type, or it can be NK type. Agar this lymphoma is a non-Hodgkin lymphoma of B type, it is 19 positive, 3 positive, और यहाँ 16 positive. But कोई भी lymphoma हो, they all will be CD45 positive. They all will be CD45 positive. ठीक है? Hodgkin disease overall is 19 negative, okay, 19 negative, 3 negative, 16 negative, and 45 negative. So all these are negative. तो पॉजिटिव क्या है? पॉजिटिव है 15 पॉजिटिव एंड 30 पॉजिटिव. अपार्ट फ्रॉम देम दे कैन ऑल्सो बी पैक्स 5 पॉजिटिव. ठीक है, तो अब ये जो हॉजकिन लिम्फोमा है, इट इज समथिंग लाइक दिस. Now the point is the Hodgkin lymphoma can again be of two types, right? It can be classical Hodgkin lymphoma or can be non-classical Hodgkin lymphoma. So that differentiation was made according to the markers positivity. Matlab, a classical Hodgkin lymphoma, it is 15 and 30 positive. A non-classical, समझो बात को, a non-classical Hodgkin lymphoma is 15 negative, 30 negative. But what happens to 20? यहाँ 20 positive है, यहाँ 20 negative है. But the point I want to make here is, whenever you get a case on Hodgkin lymphoma, they want to ask you classical Hodgkin lymphoma only. Because anyway, you will be surprised to know that the non-classical Hodgkin lymphoma has recently been put under the B type of non-Hodgkin lymphoma. So this was gone here. But anyway, you don't need to know that. But the point is, if you are asking a case of Hodgkin lymphoma, they want to ask you classical Hodgkin lymphoma only. And therefore, the answer is CD15 and 30 only, not 19 or 3. That's not possible. ठीक है, 15 and 30 both are the answer. So answer is both A and B. ऐसे करके इसका क्वेश्चन था, both A and B. I think I made a lot of sense to you. Okay, I think this is very very clear here. है ना? Clear है ना? This is how it must be understood. एकदम clear में. Okay, and lymphoma in Hodgkin lymphoma, do revise that they also are Epstein-Barr virus positive, whereas a non-classical is Epstein-Barr virus negative. EBV कितना होता है? That also you must remember. The type of Hodgkin lymphoma like mixed molality shows mononuclear cell, M for M. The nodular sclerosis shows lacunar cell, वो भी याद रखना है. And the non-classical predominant type shows popcorn cell. तो बड़ा simple याद रखो. M for M, M for M, P for P, and the nodular sclerosis shows lacunar cell. Lacunar cell. इतना कुछ याद रखोगे ना, you'll solve most of the questions. इतना ही याद रखना है बस. So Hodgkin lymphoma is what origin? B origin. From where? The germinal origin. Germinal origin. ठीक है? बस इतना ही याद रखो. ये बताओ. Absent graft versus host disease in a patient with bare lymphocyte is due to deficiency of. इसका बताओ मुझे आंसर. Okay, what do you say? Bare lymphocyte syndrome. What is the answer? But all you have you marked as the answer. Bare lymphocyte syndrome. देखो एक बात समझो. The bare lymphocyte syndrome होता क्या है? प्लीज समझो एक बात को. That bare lymphocyte syndrome, first of all, is type 1 and type 2. So bare lymphocyte syndrome is type 1 and type 2. जो type 2 है इसे कहते हैं मेजर टाइप, और type 2 जो वो रेयर टाइप है. पहले ये समझो. ओके, नाउ व्हाई इट इज हैपनिंग? इट इज ड्यू टू द एब्सेंस ऑफ द MHC gene. सो इसमें होता है MHC1 जीन एब्सेंट, एब्सेंस ऑफ इसमें होता है MHC2 जीन एब्सेंस. Because the MHC1 gene doesn't develop, there's reduced number of CD8 T cells. And here, because MHC2 doesn't develop, there's decreased amount of B cells. Why? Because CD4 T cell is low, CD4 T cell is low, and hence there is reduced number of B cells also. So there's no doubt that in this case the answer should be both the MHC1 and MHC2. But if you have to choose one, in that case the better answer is MHC2 more than type 1. समझो बात को. ऐसा नहीं है that I'm saying that it's only MHC1 or MHC2. What I'm trying to say is it is MHC2 more than MHC1. So if the question is you have to choose one, choose two more than one. But in case you have both the option, choose any one of them. Okay. Now देखो what is Bayer-Leventhal syndrome. So the Bayer-Leventhal syndrome, it is due to autoimmune recessive disease because of mutation of chromosome 1 or 16. Type 1 and type 2. तो टाइप 1 में क्या एब्सेंट है? MHC क्लास 1. टाइप 2 में क्या एब्सेंट है? MHC क्लास 2. ओके. नाउ बिकॉज MHC क्लास 1 कैसे याद करते हैं? रूल ऑफ 8 याद है ना सबको? रूल ऑफ 8. What is rule of 8? You multiply CD and your MHC, it must come as 8. तो CD कितना बच्चे? CD 8 है, MHC 1 है तो 8 बना, CD 4 है, MHC 2 है तो भी 8 बना. तो what I'm trying to say is that 1 is absent in type 1, 2 is absent in type 2, and 2 is the major one, and therefore the better answer is MHC 2 compared to MHC type 1. Clear हुआ सबको? चलो, what are the features? Increased infection, obviously, because if CD4 or CD8 is not developed, increased infections. CD4 and CD8 number will be decreased, and intracellular infection could also lead to lethal defect. Okay, there's a Bayer lymphocyte syndrome. And do not forget to revise the way that I've taught you all the primary immunodeficiency disorder. All of you must revise the PID, okay? That how the skid happens, how does the Britain's X-linked happens. All of those you must also revise with the exam, okay? Chalo. Which of the following cytokines are not associated with the Th1 cell? इसका आंसर क्या लिखा आप लोगों ने? Now, how to revise this one? Let us take out that image from which we have always done this. Okay, देखो. I'll just take out this image from here. Okay, and try to revise in our own notes. Just give me 1 minute. Okay. देखो. So when you get a question on this thing, it must be very much made clear that what is the question asking you. देखो बात को. So यहाँ पर क्या हो रहा है? APC is activating a Th1 cell. In this question, APC is activating Th2 cells, and in this case the APC is activating Th17 cells. Okay. अब देखो क्या हो रहा है? If the APC is presenting the chronic antigen, so APC would release IL-12 and IFN gamma to activate Th1. In that case, the Th1 will then release IL-2, 12 and IFN gamma. IL-2 will activate CD8 cells, 12 and gamma will activate macrophages. ठीक है? APC, if presenting as a parasite, would release IL-4 to activate Th2 cells. The Th2 cell will then activate 4, 5 and 13. IL-4 will activate B cell to release IgE. IL-5 will increase eosinophils and IL-13 will increase mucin production. ये भी clear हो गया? The APC, if they have bacteria or fungus, in that case the APC would release IL-1, 6 and 23 and will activate Th17 cells. In this case, the IL-17 and 22 is activated to activate neutrophils and monocytes. ठीक है? अब question क्या है? Question is asking you, यहाँ देखो, the following is similar Th1 cells. ठीक है? अब एक बात देखो, when you talk about Th1 cell and suppose you don't remember the entire thing here, do you remember it's for chronic antigen? Now for chronic antigen, what do you need? For chronic antigen, you need IFN gamma, you need IL-12 and you sometimes need also IL-2. So IL-2, 12 and gamma should be the answer because IL-4 is for Th2 cells. And therefore in this case, the answer is B, C and also D. B, C and also D. Now the question is, sir, do you need to rectify this? जैसे तुम बोल रहे हो, बिल्कुल नहीं. If you have attended my class before, you will clearly remember कि when I talked about the Th2 cells, समझो बात को. Whenever I talk about the Th2 cells, I always try to remember you by allergen parasite. Because it's an allergen parasite, what cells you want? IgE. You want eosinophilia, तो IgE के लिए 4 है और eosinophil के लिए 5 है. बस simple है ना. Got the point? So don't try to remember this one. Try to remember the antigens and based on that remember the TH cells. Just example समझो. Suppose the chronic antigen. So if you have a chronic antigen, what cells you want? Cells you want is macrophages and CD8 cells. To bring macrophages, you need IFN gamma and IL-12. To bring the T cells, you need the IL-2. That is, they will activate a CD8 cells. So try to remember the TH cells in reference to the antigens or the being presented to them. ठीक है, जैसे एग्जांपल समझो, यहाँ क्या है, बैक्टीरिया और फंगस. तो what cell you want? Do you want macrophages? No. Do you want T cells, eosinophils? No. For bacteria, you want neutrophils and monocytes. And hence देखो क्या है, neutrophils and monocytes here. Neutrophils and monocytes here. ठीक है, तो try to connect these dots with the help of antigens there. And just don't try to rectify this. Never, never. Pathology is not about at all rectifying this. But yes, is cytokines important? This question was asked, at least 2 questions were asked in last year INICET. 2 questions in set 1 and 2 questions in set 2. So I would suggest you to please remember this one. For activation of macrophage, if you're asked the best answer, so for macrophage, IFN gamma is a better answer compared to IL-12 or IL-2. Okay, IL-5 is for, yes, for eosinophils. चलो, match the following. बताओ ये margarine ulcer. Margarine ulcer क्या होता है? It's an ulcer on the burns, right? Margarine ulcer. ठीक है? Then a patient has sarcoma on the thigh, a big sarcoma. Look at the size also. Single cervical lymphadenopathy and solitary nodule on thyroid. So what will you do for these as diagnostic purpose? देखो, the point is, suppose you have a burn case here, and in the burn case, suppose the tumor cells have now involved and there can be an invasion. It's a margarine ulcer, right? So what you need to do is, you need to know if the tumor cells are invading below or not, and therefore you need to take out a biopsy like this. And therefore, for case of a marginal ulcer, we often try to take what? A wedge biopsy. Okay, we try to take a wedge biopsy. Why? Because you want to see the depth. Okay, why you need to take a wedge biopsy? Because I want to look at the depth. ठीक है, so marginal ulcer के लिए wedge biopsy. अब खुद सोचो, suppose there is a large tumor. Let's understand this. Simple logical है ये. The large tumor here. Okay, but you cannot take out the entire tumor. You cannot take a tumor of 8 into 4 centimeter size, and therefore in this case you just want to take a small incision biopsy here, okay, just to see whether it's a tumor or not. And therefore for this case you will do a core needle biopsy. Okay, for this you do a core biopsy. ठीक है, suppose there's a single lymph node, एक single lymph node है and look at the size, तो निकालो और हटाओ. तो what do? You do excision biopsy. Excision biopsy. ठीक है, excision biopsy. Okay, and in case of a solitary nodule on thyroid, thyroid में often the best is to do a thyroid में often the best thing you do is FNAC ultrasound guided. Okay, for this you do an FNAC, always USG guided, always. Remember, the Bethesda classification nowadays in thyroid has clearly stated that for a thyroid lesion you must do either a excision biopsy, or you can do an FNAC, which always should be ultrasound guided. Ultrasound guided. Clear हुआ ना? Therefore, the answer should be as such. हाँ जी, निकालो और हटाओ, बात खत्म. चलो नेक्स्ट क्वेश्चन चलते हैं. The patient presents with mass in the stomach. IHC is 117 positive, but cytokeratin and S100 is negative. अब बताओ, स्टमक के मास है, what should you come to is squamous cell carcinoma हो सकता है, adenocarcinoma हो सकता है, it can be lymphoma, or it can be a case of GIST, right? If it's a mass in the stomach, these 4 things should come to your mind. Now, if it is squamous cell carcinoma, If it is squamous cell carcinoma, it will give you cytokine positive. Adenocarcinoma also will give you CK positive. But because CK is negative, you have excluded this. You have clearly excluded this. Remember, for adenocarcinoma, often a TTF1 is also positive. Squamous cell cancer के लिए P53 or P63 or P40 is often positive. Hodgkin lymphoma के लिए I told you 15 or 30 or 45 will be negative here, right? And therefore the answer is GIST, because GIST is CD117 positive. तो आंसर क्या होगा? GIST. GIST क्या होता है? गैस्ट्रो इंटेस्टिनल स्ट्रोमल ट्यूमर, जिस्ट. अच्छा, जिस्ट में क्या क्या इंपॉर्टेंट है? दैट द ऑरिजिन ऑफ जिस्ट इज, बताओ जिस्ट का ऑरिजिन क्या है? इंटरस्टिशल्स ऑफ काजाल, राइट? ओके, नेक्स्ट यू शुड नो दैट व्हाट इज द म्यूटेशन. इट इज सीकेट. इफ नॉट इन द ऑप्शन तो क्या चूज करोगे? PDGFR alpha. If not in the option, then you go with SDH loss. What else you must know? You must know about the Carney's triad and Carney-Stratakis syndrome. बस इतना ही जान लो जिसमें सारा क्वेश्चन सॉल्व हो जाएगा. Carney's triad क्या है? Gist with paraganglioma and pulmonary chondroma. ये सब तीनों चीज क्या है? Carney's triad है. Okay, Carney's triad है. And GIST is a hot favorite question. Okay, one more question that can be asked is, in the microscopy of the GIST, please remember GIST is what? It's a mesenchymal tumor. If it's a mesenchymal tumor, एक बात को समझो, एडेनोकार्सिनोमा क्या दिखेगा माइक्रोस्कोपी में? ग्लैंड्स, ठीक है. Squamous cell cancer will show you what? Keratin pearls with squamous cells. But please understand, because GIST is a mesenchymal tumor, mesoderm का ट्यूमर है, it cannot show you glands, right? Because gland की origin क्या होती है? Ectoderm, right? And therefore the GIST will show you what? Spindle cells, इस तरह के spindle cells. The moment you see a spindle cell microscopy in a stomach, we always think about GIST. Simple. ठीक है? चलो. And therefore this question also becomes very very important. ठीक है, देखो, the following is true. तो GIST के लिए सीकिट obviously, KRAS for lung carcinoma. देखो, lung carcinoma में can always you can see the RAS. ERBB मतलब कि the epidermal growth factor receptor. Okay, EGFR2 or ERBB, the same name, is also is positive. But so that tumor doesn't show PDGFR beta, it shows often the PDGFR alpha. Okay, so it also shows PDGFR. So I will not go with this one. So answer is A, B, and C. Yeah, this is a mostly a factual topic, so I will not suggest you to read all the genes and mutations. That's not actually possible. But just by knowing a bit of that, you can understand that CKIT is for GIST, KRAS is for lung carcinoma, and the ERB is for breast carcinoma. The question is, what all genes we should know in case of the pathology? I'll talk about this after some the topics are over. I'll talk about it again. Okay. How to know is ERBB only. Same thing. Don't remember. So about the mutations, please allow me some time. I'll tell you what all mutations, depending upon the topics being asked here. I'll give you a list of all the mutations that you should know in case of pathology. Just hold on a bit, okay? Chalo. True about sirtuins. True about sirtuins. Bolo. Answer. Sirtuins. Multiple choice questions. It's a multiple choice question. So sirtuin increases insulin sensitivity. Yes, that's true. And thus glucose metabolism. Obviously, yes. Promotes longevity. Yes. 5 type of genes are there. There is called as SIRT1, 2, 7. So 7 type of genes. And they also type of histone D acetylase. So that answer is A, B, C, and D. Okay, all of them are true. A, B, C, and D, all of them are true. Acha, what should else know about sirtuin? So it's all written there. But remember, sirtuin is always often activated by intake of red wine. Red wine can activate this. And what is the proven way to increase the lifespan? The proven way is actually what? The proven way of increasing the lifespan of a cell, okay, is decrease calorie intake, and this should be at least by 30%. Only then you would say that the patient actually has a decreased calorie intake and can increase the lifespan. The second one here is the intake of sirtuins. Okay, what else can be asked in sirtuin apart from the increase in insulin sensitivity? The function of sirtuin can be asked. It can increase insulin sensitivity. Okay, pala. Okay, second, it can increase cell repair. It can decrease cell death, that is apoptosis, and can also activate the enzyme telomerase. Okay, so telomerase, remember, it does not cleave telomere. The function of telomerase was also asked. It can increase the length of telomere. Okay, it can increase the length of telomere. Okay, so that is very, very important. Okay, so about the increasing insulin sensitivity, that's also is true. It does not increase insulin resistance, it increases insulin sensitivity, and therefore it is also proven to have some role in decreasing the diabetes. Okay, that also can be asked. One more action is it helps in treatment of diabetes, but unfortunately the certain containing pills are not available, and therefore the only way you can actually depend upon is to decrease the calorie intake by 30% to live longer. Okay, you cannot depend obviously on intake of red wine daily. Okay, small sip le raha hai red wine ka और पढ़ाई कर रहा है, that won't happen, that will not help you. But what will help you is decreasing your junk food and decreasing the calorie intake by 30%. Decreasing calorie intake does not mean eating less, it means decreasing junk food. Okay, I think that should be very, very clear here. Chalo, the following is true regarding hemophilia A. बताओ, hemophilia A. So hemophilia A में S is factor 8 deficiency. X-linked recessive is also true. More common in males. Any X-linked disease is obviously more common in males compared to females. And mucosal bleeding is commonly. No, it happens. What is muscle hematoma and heme arthrosis. Okay, that's about hemophilia A. If the question would be hemophilia B, तो क्या होगा? Again, X-linked recessive and would be Christmas disease because deficiency of factor number 9. Factor number 9. और अगर hemophilia C है, ठीक है ना? Hemophilia B है तो factor 9 deficiency. Hemophilia C है तो factor 11 deficiency. बस इतना याद रख लो. चलो, next question. About hereditary spherocytosis, which of the following is correct? Okay, so at least 25% have family history of HS. देखो, HS is autosomal dominant, right? And hence the first option is true. High MCH is pathognomonic. No, high MCHC is pathognomonic. This one is false. Gallstones develop by 4 to 5 years of age. No, gallstone will not develop so early. Gallstone will develop around 25 years of age. This also is false. It develops around 20 to 25 years of age, will not develop so early in the life. Splenectomy does not interfere, does not protect against developing of gallstones. No, so it definitely protects. Okay, this also is false. So the answer is only A. So why is the option C not correct? Because gallstone ka the development hota is not so early in life. Okay, it takes at least 20 to 25 years for the gallstones to develop. Okay, now the question is, sir, why is MCHC increased? One of the answer is, देखो, if you take the normal RBC, ये normal RBC है. Okay, तो normal RBC में the shape of a normal RBC, it would be something like this, ऐसा. Okay, with the central pallor. But when you take a spherocyte, the size will decrease, right? This is spherocyte, ये normal है, and this one is spherocyte. So what is happening is the equal amount of hemoglobin has to be now compensated or put in small volume of the RBCs. And when these RBCs make a packed volume, the packed volume, what is MCHC? MCHC is nothing but hemoglobin by packed cell volume. But when you take the packed cell volume, so because the MCV has reduced, the PCV will also reduced. Hemoglobin is same, but PCV is decreasing, and therefore the MCHC will increase in case of HS. Why? Because spherocytes may the PCV will decrease. Okay, the PCV will decrease more than the decrease of hemoglobin, and therefore the MCHC will increase in case of the hereditary spherocytosis. The only case where the MCH increases is hereditary spherocytosis. Okay, spherocytosis. What else you should know? In case of HS, it is ankyrin, okay, more than band 3, more than spectrin. So most common is ankyrin. Second question is most severe or most severe deficiency or disease occurs in, remember, spectrin deficiency. Second, third, hereditary elliptocytosis, again spectrin deficiency. So all of these questions can be asked in case of hereditary spherocytosis. Okay, what is the treatment in HS? You give blood transfusion, you give B12 plus folic acid in case of the anemia. Okay, blood transfusion. If nothing is helping out, in that case you do splenectomy. But splenectomy, even though will decrease the hemolysis, will increase the amount of spherocytes. Was also asked in last to last year's INICET. Okay, if you remove spleen, the anemia will decrease. समझो बात को, the anemia will decrease, but the amount of spherocytes will actually increase in that case. Okay, yes. The shift of the OFT, that's again is very important. So OFT का अगर curve देखोगे, मान लो कि ये curve है, there is a percentage NaCl on the x-axis and percentage lysis on the y-axis. So suppose the normal curve is like this. Okay, this is a normal curve. Okay, and this is suppose 0.1% here and 0.9% here. So HS would be right shifted. ये HS का curve होगा, HS. Okay, and the micro side will be left shifted. ऐसे micro side will be left shifted and HS would be right shifted. बस इतना याद रखो. Right shift for HS and microsite would be left shifted. That's it. Okay. Chalo. Next, move to next question. A patient underwent surgery 1 year back, now presents with fatigueness. Investigation shows macrocytic anemia. The following rejection will not cause a following condition. अब देखो, this is a question, but I know that many of you will again make it wrong, and therefore I just put you an image of Robbins here. So let's talk about how does a B12 absorption occur. देखो, so when you take a B12, the B12 is bound with protein. The salivary gland will release something called as hepatocorrin. But hepatocorrin does not bind to B12 because B12 is already bound to proteins. Okay. So now these both will come to what? Will come to the stomach. So do they bind in stomach? No. Again, no. They do not bind in stomach. So stomach may there's surely a release of parietal cells. Okay. The parietal cells will then release what? Pepsin. Okay. And will also release what? Intrinsic factor. They call intrinsic factor. Okay. So have they bound in the stomach? No, not again. So they are again brought to the duodenum. In the duodenum, what happens is the pancreas will release pancreatic enzymes, and therefore now the B12 and hepatocorrin, which actually bound in the stomach, will now separate out. So B12 will now separate out with hepatocorrin, and the intrinsic factor will bind in the duodenum. Now they will come to the jejunum. Here nothing happens. And then they are brought to the ileum, and in the ileum they can be absorbed with the help of intrinsic factor receptor in the terminal ileum, and they can be again captured with the transcobalamin 2 and can be taken to the liver. That means the major sites responsible are surely the stomach, duodenum and terminal ileum. So which part removal will not cause the condition? The answer is jejunum. Okay, so removal of jejunum will not cause such type of anemia. Okay, remember, first of all, this can also be asked as what is the protein that binds to the B12. So first is what? It is food may B12 binding protein. From salivary gland, hepatocorrin. Okay, from the stomach, intrinsic factor, and finally in the terminal ileum it is intrinsic factor receptors. Intrinsic factor receptors in terminal ileum will actually bind there. Okay, chalo. Now this is again is a bit confusing question. Now what do you think is the answer here? Batao. Dystrophic calcification is not seen in. Okay, not seen in. Batao. So first of all, देखो, in CKD you see metastatic calcification. Metastatic calcification. Why? Because in CKD ultimately there is increase in PTH hormone, right? And because of hyperparathyroidism there can be increase in the calcium levels. Okay. In hyperparathyroidism, again is metastatic calcification, no doubt about it. Vitamin D has increased calcium, so again has metastatic calcification. But when you talk about the metastatic lymph node, so this lymph node often show necrosis, and therefore it causes dystrophic calcification. It then causes dystrophic calcification. So the answer is B here, not C. Okay, because dystrophic calcification is not seen in. Sorry, तो आंसर क्या होगा? Sorry, dystrophic calcification is not seen in. The answer would be metastatic is seen in A, C, and D. All of these three, they will show you. All of these three, they will show you the metastatic calcification. ध्यान रखना. Dystrophic calcification among these will be seen only in metastatic lymph node. Now the question is, sir, how to remember this? Very confusing. देखो, dystrophic calcification versus metastatic calcification. समझो बात को. Remember the D for D, मतलब dead oblique degenerated. First thing, calcium level here is normal. Second thing, okay, an example is RATT rat. Rat matlab rheumatoid arthritis, atherosclerosis, the TB and some tumors. ठीक है. In the metastatic calcification occurs in living tissues. पहला, the calcium level is increased. And what are the causes? Any cause of hypercalcemia. So what are the hypercalcemia causes? It would be, first of all, a CKD. Why CKD? Because it causes increase in parathyroid hormone and hence it can lead to hypercalcemia. Yes, CKD can also lead to hypocalcemia, agreed. But that hypocalcemia cannot cause calcification at all. So forget about this. Don't confuse yourself to a case of CKD में there can also be hypocalcemia. Agreed, bhai, hypocalcemia can occur. But if hypocalcemia can occur, why will it cause calcification? It cannot cause calcification, right? And therefore, right now, in this case, it can cause metastatic calcification owing due to the hypercalcemia. ठीक है. Second, it can be sarcoidosis or any cause of granuloma, because granuloma also causes a release of vitamin D. So granuloma, like in TB, not in sarcoidosis, not in TB, sorry, in sarcoidosis. ठीक है. Apart from this, in vitamin D toxicity, it can also occur in multiple myeloma. Okay, multiple myeloma. Why again? Because this can also lead to hypercalcemia. Okay, can also lead to hypercalcemia, and obviously in hyperparathyroidism it can also happen, and something called as milk alkali syndrome can also lead to metastatic calcification. Okay, now sometimes the students ask me in the previous question, Ki sir, why in this question, why not jejunum? Why not duodenum? Because duodenum has only the risk in only absorption of iron. You are saying that folic acid can be absorbed in jejunum. Agreed. But folic acid can also be absorbed in the ileum and can also be absorbed in the duodenum. Okay. So it's not a specific site for jejunum only. Chalo. Next question. I think we have already discussed this. So this is already done. इसको आगे बढ़ते हैं. Iron staining is done with the help of simple question. बताओ. Iron staining. क्या होगा आंसर? Iron staining बताओ. Yes, the answer is iron is done in, yes, it is Prussian blue. Very good, Prussian blue. ठीक है. अब देखो, what you must know is that in case of the iron stain, this is some stains very important. Okay, there's some stains which are important. Like if you talk about the fight Faraco staining, it's often is used to look for the Mycobacterium leprae. Okay, is often used for the Mycobacterium leprae. Okay, Mycobacterium leprae staining. Okay. Okay, it's acid fast staining obviously, and it's often used in the Mycobacterium leprae. Okay, it's an acid fast stain. Acha. So, sir, what are the other stain that we should remember? I just make a small list for you all. Dekho. So, for the staining like glycogen is important. It is actually pass positive, and remember it is diastase sensitive. Okay, then there is lipid. For lipid, two states are important. One is oil red O, and one is Sudan black B. Sudan black B is often used for a fresh tissue. Remember that thing also. Then for a protein, we often depend upon the pass again. It's pass positive, but it is diastase resistant. This again is important. For the other thing, you must remember that for the calcium, we use often the von Cossa and alizarin red. This has been again a asked question. Then for the minerals, you can be asked about iron, you can be asked about melanin. Okay, for iron it can be pearl stain, or you can see this Prussian blue staining. For a case of melanin, it can be Mason Fontana. It can be Mason Fontana. Okay, Mason Fontana. Apart from this, for collagen, it is the Mason trichrome stain. Okay, Mason trichrome stain. Then for the basophil or the mast cell, it is toluidine blue. Okay, toluidine blue. For mucin, we use Alcian blue stain. For mucin, we often use Alcian blue stain. So I think this is what is all important for all these conditions. Okay, so these are the various components and the special stains are written on that side. I think this is really more than sufficient. Now if you get anything else, you can add up here, but these are the often asked question you'll get in a NEET PG or INICET. That's really more than sufficient. IHC I'm not putting it here, only the special stain I'm putting it, not the IHC. This is a list for special stain only, not for the IHC. IHC, the special stain altogether, I have not included the IHC in this case. Okay, चलो ये बताओ, eggshell calcification is seen in, so this is both pathology and radiology. So eggshell calcification is seen in, yes, silicosis, sarcoidosis and lymphoma after radiotherapy. So the answer is A, B and D. Okay, so remember eggshell calcification is seen in silicosis, sarcoidosis and also lymphoma after radiotherapy. Okay, chalo, a patient with hemoglobin of 9.8, MCH of 24, MCV of 65, ठीक है, ferritin of very low 10, platelet count of 5 lakhs, WBC of 11,500, there is anisopoikilocytosis, microcytic RBCs are given in the pelvis smear here, and this is a almost a teardrop RBC like looking like cell. There's a huge amount of hypochromia here. So जब you like get an image like this, the first thing you must look is if you can identify a normal RBC. So normal RBC is how? Normal RBC is a RBC having a central pallor 1/3 diameter of the complete RBC. So in this case, if you look at the normal RBC, देखो this is normal RBC, ये normal है. Now, if you compare this normal RBC to most of the RBC here, most of the RBC here are hypochromic. क्यों? Because if you look at the normal RBC, the pallor is 1/3, ऐसा होना चाहिए. But here you see the RBCs, they're mostly like this, ऐसा है ना? So this is what? It's a hypochromia. And if you look at this one, it's a pencil cell. It's a pencil cell. So with this cause of low MCV, MCH or MCHC, MCV, MCH or MCHC, it would be case called as iron deficiency anemia. Would be called as iron deficiency anemia. Iron deficiency anemia. ठीक है? It's a case of iron deficiency anemia. ठीक है? चलो. A 38-year-old female with a vegan diet presents with fatigueness. CBC shows a hemoglobin of 7 gram percentage. ठीक है? MCV is 110. And methylmalonyl coenzyme A is normal while homocysteine is increased. अब बताओ, what do you think it is? But in this case, what you understand is it's a case of, yes, macrocytic anemia. Why? Because the MCV is so high. MC is very high. It's because of macrocytic anemia. It could be either B12 or folic acid deficiency. I understand one thing. Usually, the B12 is in the non-veg foods and folic acid is in the vegetarian foods. Okay? Now, the point to understand here is, देखो, there's a reaction. Homocysteine will convert to the methionine in case of B12 and folic acid. ठीक है, ये clear हुआ? And if you talk about the methyl malonyl coenzyme A, it converts to succinyl coenzyme A with the help of B12. ये में क्लियर हुआ? ठीक है? ठीक है? अब देखो, the point is if you talk about succinyl coenzyme A to methionine coenzyme A and methyl coenzyme A with succinyl coenzyme A, so अगर if a patient, समझो बात को, if a patient has a deficiency of B12, so his methyl coenzyme will increase and this will also increase. However, if the patient has a deficiency of folic acid, this one, in this case, this would increase, but this would remain normal. And therefore, the answer is folate deficiency. Folate deficiency. ठीक है? Folate deficiency. And when there's deficiency of B12 folic acid, you must give B12 and folate both together. Why? Because when you give only the folic acid or a B12, sorry, suppose you give only B12, so what happens? All the folic acid remaining will go towards making only and only the DNA. Whereas the neurological manifestations, because this reaction, methyl malonyl coenzyme A, requires B12, right? So if you give B12 only and not folic acid, you only give B12, this will go on increasing. Okay, this will go on increasing, this one. Okay, so all the folic acid right now would be used to make homocysteine to methionine. But this will not happen. And therefore, it is called as folate trap. We'll talk about this in a separate question altogether again. But now, right now, remember that the B12, when folate trap actually means that the B12 is used only, and all the folic acid goes on to making DNA only. And because all the folic acid remaining goes to make DNA, there's no folic acid now remaining to make the myelin chain, because myelin is composed of fatty acid and fatty acid is composed of succinyl coenzyme A. So if you are not giving the folic acid together, there's a disbalance between the production of DNA and the fatty acids. Because the fatty acid decreases, the neurological manifestations will actually increase in those patients. Okay. Now look at this question. The following cytokines are released in case of Jarisch-Herxheimer reaction. Jarisch-Herxheimer reaction. ये बताओ. In Jarisch-Herxheimer reaction क्या होता है? First of all, remember it is after the antimicrobial, okay, antimicrobial therapy in or after syphilis, after antimicrobial therapy in syphilis therapy. Ab, what happens when you give this? There is a increased amount of cytokine release, and the cytokine release causes fever and inflammation. This is called as Jarisch-Herxheimer reaction. So what all cytokines are mainly important there? The cytokines involved in Jarisch-Herxheimer are, first of all, TNF alpha, interleukin 6, and also interleukin 8. The three cytokines are most important. If you want to choose one of them, the best answer is TNF alpha, but IL-6, IL-8 are also important there. So with these are the options, the answer is TNF alpha, IL-6, and also IL-8. It is 1, 3, and 4. 1, 3, and 4 are the main cytokines responsible in the Jarisch-Herxheimer reaction. ठीक है, चलो next question. And with the correct statement. And this question again depends upon your knowledge of the cytokines. Okay. So I hope you all remember cytokines right now. देखो यहाँ पर. So I explained you. कहाँ गया? We had so many questions. Wow. Okay, देखो ये वाला. Remember for the TH1, IL-2, 12 gamma. For TH2, 4, 5, 13 and 17 के लिए 17 and 22. Clear? अच्छा. Based on this, let's look at that question. देखो. Correct statement. So IL-12 activates macrophage. That's true. 12 suppresses T cells. No, definitely not. IL-12 inhibits cytotoxic T cells. No. Okay. TH2 activates IFN gamma. That also is true. So the answer is A and D. So please remember, you will surely get a question on the cytokines. And the simple way to remember is, remember Th1 cell, Th2 cells, and Th17 cells. That's a simple way to remember. IL-1 के लिए क्या याद रखोगे? Th1 के लिए IL-2, IL-12 एंड इंटरफेरॉन गामा. ठीक. Th2 से इंटरलोकिन 4, 5 एंड 13 और Th17 से 17 एंड 22. इतना याद कर लो. रियली सफिशिएंट. इट्स रियली सफिशिएंट. ठीक है. चलो नेक्स्ट क्वेश्चन. पुअर प्रोग्नोस्टिक फैक्टर्स फॉर ALL आर ऑल एक्सेप्ट. सो पुअर पूछ रहा है. सो फॉर द ALL you must always remember the table for prognosis. Always. It's very frequently asked. So how to remember that? Dekho. First of all, the simple way to remember for ALL, I'll say the cytogenetics for good and poor prognosis. When I talk about the good prognosis, good, and the poor prognosis, remember, is translocation of good में क्या क्या आएगा? 12 उल्टा करो 21. That's it. बस इतना याद कर लो, more than sufficient. If the chromosome number is more, it's still good. So trisomy of 4, 10 and 17 or hyperdiploidy, these all have good prognosis. Good prognosis. Whereas hypodiploidy में क्या क्या आता है? 5 with 14, 9 with 22 and any chromosome with 11. 5, 14, 9, 22 and any chromosome with 11, and along with that hyperdiploidy, they also have poor prognosis. So कैसे याद करेंगे? देखो 12, 21, 12 उल्टा करो 21, 12 करो उल्टा करो 21. So 12, 21 is good. बस एक याद कर लो, 12 उल्टा करो 21, that's good, and anything else is bad. So in this case, when the question is poor prognostic factors are all except, so 411 is surely poor, 922 poor, less than 1 is again poor, high probability is good. So answer क्या हुआ? D. Answer is D. Okay, answer is D. अच्छा ये हाइपो होगा, सॉरी ये हाइपो होगा, वेरी सॉरी हाइपो, वेरी सॉरी हाइपोडिप्लॉइडी. ठीक है, थैंक यू. हाइपोडिप्लॉइडी. सो ट्राइजोमी, ये सॉरी, ओहो दिस इज हाइपर और यहाँ होगा हाइपोडिप्लॉइडी, वेरी सॉरी हाइपोडिप्लॉइडी. Okay, hypodiploidy. That's a poor prognosis. Sorry, sir. हाँ, clear है? चलो. A 11-year-old child with diagnosis of rheumatic fever without valve damage. What is the duration of secondary prophylaxis required? बताओ. Without valve damage. So this is solved by usually this type of reaction. First of all, remember the secondary prophylaxis. The primary prophylaxis is benzyl penicillin. The secondary prophylaxis is often again benzyl penicillin. You can also give a macrolide or erythromycin in case the patient or a child is penicillin allergic. Macrolide or erythromycin can also be given in case a child is penicillin allergic. Now remember this question. देखो. In case of rheumatic fever without carotis, it should be for 5 years or until 21 years, whichever is longer. ठीक. Rheumatic fever with carotis and no residual heart damage. No residual heart damage. क्या क्वेश्चन पूछा था ऊपर देखो? 11 years with rheumatic fever without valve damage. यहां पर क्या था पहले? Without carotis. Second क्या आया? With carotis. 10 years or up to 21 years of age. And if it is carotis and residual heart disease, in that case again 10 years or up to 40 years of age, whichever is longer, sometimes even also lifelong. So if the question is asking you without carotis, in that case only 5 years. With carotis, no valve damage, 10 years. With carotis and valve damage, it is 10 years or up to 40 years of age. So in this case, what is the answer? It is diagnosis with rheumatic fever without valve damage. The answer is 10 years, not 5 years. Why not 5 years? Because if the question is a rheumatic fever without valve damage, but he has a rheumatic carotis. Okay, so I think this should be question with carotis and without valve damage. Sorry. and without wall damage. In that case, it is 10 years. However, if it is cavities with wall damage, in that case, it is 40 years. Okay, in that case, it's 40 years. Okay. Okay. So answer is 10 years. A 45-year-old male presents with history of fever, weight loss, hepatitis, is Salon's deformity. On X-ray, multiple cavitation lesions are seen. On lung biopsy, granuloma with giant cells are also seen. Granuloma with giant cells are also seen. So what do you think is the answer? There is a Salon's deformity. There is multiple cavity lesions. Okay. And there is granuloma with giant cells. Case hitting granuloma with giant cells. Well, the answer is vaginous granulomatosis. Why? Dekho, when you get a case like this, I'm very sure you might be confusing this cell with TB. TB surely has a case-hitting granuloma with giant cells. TB may have cavitations, but usually a TB is not very commonly there to present with saddle nose deformity. And therefore, the right answer is vaginous granulomatosis. Remember, when you get a question like this, you have three things to actually differentiate. It could be Churg-Strauss syndrome, vaginous granulomatosis, and microscopic polyangiitis. The way to differentiate them is first to look at the ANCA. So ANCA has a mnemonic of PCM, but the P ANCA is seen in Churg-Strauss and vaginous. C ANCA is seen in the vaginous granulomatosis. Then look for the RPGN like finding. RP is seen in all of them. Okay? Then look at the allergy or asthma like history. Asthma like history is seen only in Churg-Strauss, not in these others. Then look for the granuloma. So granuloma is seen in the first two, not in this one. So now comes the question of how to differentiate that. So if you get a vaginal granulomatosis, in that case you'll always get, please remember, in vaginal granulomatosis you'll always get a history of upper respiratory infection plus lower respiratory infection, lower and upper RTI. This is very, very important in the case of vaginal granulomatosis. So what is upper and lower? In the upper, it can be ऊपर से शुरू करो, otitis media, pharyngitis, sinusitis. Okay, it could be a case of pharyngitis. Okay, it could be laryngitis, it could be otitis media, it could be sinusitis. It can also be a Salon's deformity and septal perforation. In the lower tract infection, it could be a pneumonia-like findings, not pneumonia, pneumonia-like findings, infiltrates, often mimics the pneumonia-like infiltrates. Okay, and along with that, they can be having lung cavitations. So lung cavitations can be seen surely in case of vaginous granulomatosis also. That is how you must actually have solved. Vaginous surely has caseation. Okay, vaginous granulomatosis can also have caseating necrosis. Please remember this. Do not get confused. Vaginous will also have caseating cavitations, and caseating granuloma can also be there in vaginous granulomatosis. There's no confusion there. Okay. Chalo. Adolescent girl of 20 years of age operated shows the following. So what do you think is this case? Well, this is what it's a actually ovary, and in the ovary you can see there is a ball of hair. Okay, this ball of hair is often matching with a case of mature cystic teratoma. So why it is not immature teratoma? Because this will show you malignancy, and because of malignancy you will see undifferentiated germ cells, not differentiated. A mature will show you differentiated I'll say ectoderm, mesoderm, and endoderm. But if the same three are undifferentiated, it goes in favor of immature teratoma. So why it is not serous cystadenoма? Because this will show you clear fluid. Okay, will show you clear fluid. Only then it is serous cystadenoma. Why not mucinous? It will show you thick mucin. Thick mucin in case of mucinous cyst, and hence it is not also mucinous adenoma. And therefore the best answer is mature cystic teratoma. I hope you got the point. Mainly confusion occurs between students is to how to differentiate mature versus immature. अगर mature होगा तो आपको क्या मिलेंगे? Ectoderm component. लाइक क्या मिलेगा यहाँ पर? Hair मिलेगा. Okay, or you can see the sebaceous cyst, sebaceous secretion, simple. Okay, okay, in mesoderm you can get the bone or muscles like this, and endoderm obviously is the uh, germ cell layer there automatically. Okay, one thing may happen is sometimes the mature teratoma, they can go towards a more dermal specialized teratoma. That means they can sometimes make only T3 T4 hormone called as struma ovary, or they can release 5 hydroxytryptamine. It is called as carcinoid syndrome. So those two can also happen in case of a mature cystic teratoma, but those are called as the specialized teratoma. Okay, what do you call them? Specialized teratoma. Teratoma is of three types: mature, immature, and specialized. Bolo, mature, immature, and specialized teratoma are the three types of teratoma. Okay, chalo. Next question. Hereditary angioneuric edema occurs due to deficiency of. So in this case, I will explain you one very very important finding of, or flow diagram of complement. Dekho. Yeah, this one. I'll just take it out from here and explain you there. Dekho. So complement is one thing you must all revise before the exam. Dekho this complement. So what happens in complement? Three pathways. One is a classical, one is lectin, and one is alternate. Classical, lectin, alternate. What you must remember is the classical activates from C to C1, activating C2 and C4. The lectin activates C3. Alternate also activates C3. So all of these three activate directly C3. Okay. What happens is alternate directly, lectin directly, but classical requires C1, C2, and C4 and then activates C3. C3 activates the breaks into C3A and C3B. C3B will then activate C5 and C5 will then break into 5C5A and C5B. This 5B will then react with C6, 7, 8 and 9 to form membrane attack complex, and as the name says, MAC, membrane attack complex, will actually break the membranes. Okay, they break the membranes of the gram negative cell wall of bacteria. ये clear हुआ? अब देखो, the C1 activation is often regulated by the C1 esterase inhibitor. Okay, C1 esterase inhibitor. C1 esterase inhibitor. ठीक है? So what may happen here is that if this one is deficient, then more C1 can activate, and hence the disease is called as hereditary angioneuric edema. What happens in alternate is it is often normally inhibited by CD55 and factor INH. If a patient has deficiency of CD55, he is suffering from PNH, and deficiency of factor INH causes atypical HUS. Okay? Deficiency of this early part of the classic complement pathway, they increase risk of SLE, and deficiency of the late complement often causes MAC deficiency, and this causes increase in the gram negative bacteria. Why? Because MAC often destroys what? The thin cell wall, and which has thinner cell wall? The gram negative, and hence it can lead to increase in gram negative bacteria. That is the Neisseria infections can increase. Okay. Okay, चलो. So इसका आंसर क्या होगा? Yes, the answer is, as you told me, C1 esterase inhibitor. C1 esterase inhibitor deficiency. ठीक है, चलो. Epstein-Barr virus target is receptor on which one? B cell. बताओ. Answer please. Yes, the right answer is very good. The right answer is CD21. Okay, so CD21 is also called as complement receptor type 2. Okay, so what you should know is that on the B cells, remember one thing, that on the B cell, मान लो ये B cell है, there is alpha and beta. Okay, and there is IgM and IgD. There is surface IgM and IgD on which the B cells act. Okay, ये antigen है. So on the B cell is also a C21 assay. C21. So when these two act, as I told you in the above question, they activate complements. The complement will act on this one. And the important fact is the Epstein-Barr virus also enters a B cell via CD21. That's also is very, very important. Okay? Chalo. Non-smoker female has adenocarcinoma lung. What IHC markers may be positive here? So what you see in this image is you can really clearly see the glands. They are malignant glands. And what you see inside the gland, these are all the mucin. ये क्या है? The mucin here. ठीक है? The mucin here. तो ये क्या है? ये mucin है. And you see the malignant glands here. And hence the case of what? Adenocarcinoma. Now the question is, what is the IHC of adenocarcinoma? देखो समझो बात को. P40 is the IHC of squamous cell carcinoma. Chromogranin is a positive of neuroendocrine tumor. Okay, NET. TTF1 and napsin are the surely the markers for adenocarcinoma. So I think here we need to know IHC details that you must remember for the exams. Okay, IHC. Usually what I tell you in my classes is you can forget your name. Do not forget IHC. It's so important. It's so important. The IHC is so important. देखो IHC for the tumor. If the tumor is a carcinoma, it is cytokeratin. It is cytokeratin. If it is okay, squamous cell carcinoma, it is P40, P60, and P53. If it is adenocarcinoma, TTF1 and napsin. ठीक है? If it is melanoma, it is HMB45. ठीक? HMB45. ठीक? Then if it is a case of LCH, it is S100. ठीक है? S100. ठीक है? LCH can also use CD207. It is called as Langerin. Langerin. LCH is also CD207 और Langerin. ठीक है? ये भी क्लियर हो गया? अच्छा. इसके बाद if the question is on neuroendocrine tumor, it is synaptophysin. Okay, synaptophysin, chromogranin, neuron specific enolase, and also CD56. Also CD56. ठीक है? Okay. Then if it is a case of glioma, it is GFAP. ठीक है? If it's a case of mesenchymal sarcomas, it will be positive for the vimentin. And in case of a rhabdomyosarcoma, obviously vimentin, but also desmin. V क्या है? Vimentin है. Also desmin. Okay. Okay, bombesin may be positive. Bombesin is not a very good marker, but yes, bombesin can be positive also in a neuroendocrine tumor, but not very, very important marker. Okay, so I have not mentioned here. But these markers are must and must remember. I can tell you one fact that IHC is a sure shot question in a case of NEET. Sorry, INICET. Pakka. Very, very important. ठीक है? ये बताओ. So how many of you are still listening to me? Are you still there? How many of us still listening to me? कितने लोग हैं present? All of those who are present, mark a presence by putting a like on the video. Okay, let's see how many of you are present. Just put a like on the video. I understand how many of you are there. And how long are you going to stay with me? That's even more important. कितना देर रहने वाले हो? Because I have some more questions to discuss here. हाँ, आग जल रहा है बिल्कुल. Very good. नदीम, आदित्य, भाग्य, शिवम, सयन, शिफाली, मंदिरा, अरे वाह, सिंबू, वरुण, श्रीलक्ष्मी, मनीष. Good, 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 good. We'll try to complete all the INICET questions, so you need not to worry about the questions at least. Okay. As long as it goes. Very good. 1 hour more. ठीक है. 1 hour तो हम पढ़ाएंगे कम से कम. Till the session you are there. Good. Have you all put a like there? चलो मैं भी एक like डाल देता हूँ तुम लोगों के लिए. Very good. How many questions to go? Yeah, that is a big mystery. I'll not tell you right now. चलो इसका आंसर बताओ. A 26-year-old a patient with 5 gram percentage hemoglobin and retic is 9. What is the correct retic count? ये बताओ आंसर. So it is actually a case of percentage CRC, right? CRC. So CRC is what? Retic percentage into hemoglobin oblique hematocrit of a patient divided by hemoglobin or hematocrit of a normal person. In this case, retic is how much? Retic is, bolo. Retic is 9 into 5. Normal is 15. कितना हुआ? 3. तो आंसर हो गया 3%. Clear. 3%. Very good. 3%. है ना? चलो. ये आया क्वेश्चन. अब फंसा सब लोग. बताओ. हेमोसाइटोमीटर प्रिंसिपल इज बेस्ड ऑन व्हाट प्रिंसिपल? बताओ. हेमोसाइटोमीटर प्रिंसिपल इज बेस्ड ऑन acid hematin. Acid hematin. So what is acid hematin? देखो, this is the basic idea there. What happens in hemocytometer is you take the patient's blood, okay, and you mix with the 0.1% HCl. It is called as acid hematin. What do you call this? You call this acid hematin. Now this acid hematin color has to be matched with comparator. ये देख रहे हो? देखो, what did you do is you take a test tube here, like it's a tube like this, okay, it's a tube like this. Okay, now in this tube there's a graduated tube. Okay, you take this tube, put the acid hematin and you place this tube here as a. Now the tube color initially is more darker. You keep on adding the water to just mix and dilute this drop by drop to match with this color. When the color matches, the point you see here, suppose 10, sorry, it is suppose 20, 18, 16, 14, 12 like this. Suppose the color matches at this point, and at this point suppose the written there is 12. They'll say there's 12 gram percentage for the patient. That means what you do here, you take, ये देखो क्या लिखा है मैंने, you take blood, patient's blood, and you mix with 0.1 normal HCl. It is called as acid hematin. Then you put this test tube in the box and keep on comparing this to the color beside it. So if it is not matching, you keep on adding water drop by drop, and then you look at the hemoglobin. Whichever hemoglobin is written there, it is that hemoglobin of the patient. However, now the question is, which hemoglobin cannot be tested by this method? The answer is self-hemoglobin and carboxyhemoglobin cannot be measured by this method. Okay, not for self-hemoglobin and carboxyhemoglobin. These two methods cannot be done by these two. Okay, they cannot be done by these there. Self hemoglobin and carboxyhemoglobin, they actually cannot be used for such conditions. Clear है? चलो, हाँ सबको अब फिजियोलॉजी के प्रैक्टिकल याद आ गए. द फर्स्ट ईयर याद है? इन दोज डेज न्यू all of us were MBBS graduates and we're so much enthusiastic to do that. In fact, in my medical college, one of my very dear friend, when he put a small nick on his finger to get the blood for the blood grouping testing, he fell down. He had a fracture in his great toe. Abhi to he's a surgeon. I don't know how he's operating, but that was the days it all started. अपने खून से किया था प्रैक्टिकल है, बड़े बड़े लंबे लंबे देने वाले आ गए. वाह, क्या शायरी है. Iron overload investigation in thalassemia major patient who has a hemoglobin, multiple blood transfusion, best investigation is. ध्यान रखना. So if you get a case of iron overload, the simple test to get that is serum ferritin. Okay, it's a straight line mentioned in Wintrop's that for a case of iron overload in case of thalassemia, there's no need of doing a biopsy. There's no need of doing any other investigation. The simplest way is serum ferritin estimation. Serum ferritin estimation. Serum ferritin estimation. ठीक है? चलो, next, previous to previous year, the following genes correctly with their tumors. बताओ. So when you talk about c-MYC, I think this is very easy. c-MYC is with Burkitt lymphoma. The n-MYC is for neuroblastoma, N for N, okay, R for retinoblastoma. So I think these are very simple to match. Now, because you don't know what PLAG, don't worry, you can then match it later on. It is pleomorphic adenoma. So remember, c-MYC is for Burkitt lymphoma. So it is A ka 2, okay, A ka 2, B ka there's 1, C ka 4, and the D is 3. Okay, this simple हो गया. चलो, the following marker for natural killer cell, NK cell, NK cell marker बताओ. So देखो, NK cell का marker, CD marker के रिवाइज करते हैं. It is CD16, 56 and 94. The answer is CD94. Now, when you revise this CD marker, again a very very important topic. देखो, तो मैंने CD marker on cells on the left side and CD marker on the right side. क्या क्या रखना है इसमें? The immature, that is blasts. Okay, the marker for blast is CD34. White blood cell marker is CD45. ठीक है. The marker for myeloid cell is simple, M for M, MPO. Okay, for lymphoid अगर B है, T है और NK है, very simple. B के लिए 19. Okay, so if you remember 19, very simple, remember others, 19, 20, 21. Just I am writing 19 से लेके 19 20, 21, 22, 23, 24, 24 तक. Okay, T के लिए 1 से लेके 8 तक. NK का 16, 56 and is added 94. Mono is a 4-letter word and both the markers are 4 at last, 14 and 64. तो 14 हो गया और 64 हो गया. So simple to remember is mono is a 4-letter word and both the markers are 4 at the last. ठीक है, 4 at the last. So एकदम simple रखना. B के लिए 19, T के लिए the main is 3, but apart from 3, 1, 2, 3, 4, 5, 6, 7, 8. Okay, NK के लिए 6, 6. Mono के लिए 4, 4. So, but this is a very unique thing. If you can remember, it's very, very simple in that case. Okay, that's how you must remember the CD markers. Nothing more than that. Nothing more than that is required. Okay, तो इसका आंसर क्या होगा? CD94. Okay, अच्छा, 25. Even though not about T25, but 25 is a marker of T regulatory cell. Now, this cell actually decreases the autoimmunity. Okay, decreases autoimmunity. Okay, it's suppress, I should say. It should suppress. It suppresses autoimmunity. ठीक है. 68 is often a monocytic and macrophage marker. ये सब पूछा नहीं गया है, but still if you just want to know, mono and a macrophage marker. ठीक है. So ratio of T cells and B lymphocytes in the peripheral blood of a normal healthy individual is. देखो again क्या होता है, प्लीज समझो बात को. That T cell and B cell, what do they do? First of all, B cell and T cell. Very surprising to most of the students is the ratio of B and T cell. What is more? First of all, remember, if you talk about the B cell, T cell, NK cell, NK cell is 10 to 15%. Okay, around 60 to 70% is T cells, and B cell is around 10 to 20%. So if you look at this ratio, then the B cell is obviously less than T cell. So ratio of T to B cell should be, it should be 3:1. If not in the option, you can also go with 4:1. Okay, 4:1, 3:1, but this become very simple. It's 3:1 in this case. Answer is 3:1. Okay, clear hai? Chalo. The following is not a part of innate immunity. Not a part of innate immunity. Dekho. First of all, remember that B lymphocytes, they become a part of adaptive immune response. Adaptive immune response. अच्छा, alpha defensive क्या होता है? It's actually a enzyme, okay, in neutrophils, in primary granules of neutrophils. So देखो, because there's so many innate immunity cells, I think the simplest way to remember is try to remember the adaptive immune system. Adaptive immune system, कि देखो कैसे याद रहेगा? Innate and adaptive. So in the adaptive, very simple to remember, B cells, T cells, right? What do B cells make? Antibodies via plasma cells. So B cells, T cells, plasma cells, and antibody, they all become adaptive immune system. And everything else is innate immune system, right from the skin epithelium, the mucosa of GIT, or mucosa of any epithelial barrier, right? It can be complements, it can be white blood cells, WBCs. So which WBC is not a part of adaptive immune system? So innate immune system, obviously lymphocytes. But NK cells become a part of innate immune response. And one thing which I've seen students often they often forget is pattern recognition receptors. Okay, acha. Ab dekho, a big confusion. Sir, what is this one? What is the gamma delta lymphocyte? So why are you putting this one in a case of innate immunity? So dekho, the lymphocytes, remember the T cells. The T cells are often CD4 T cells, CD8 T cells, the C25 containing T reg cells, and the gamma delta T cells. The gamma delta T cells, this one, is often present in the GIT mucosa. Okay, कहाँ होता है ये? GIT mucosa में, and they prevent the antigen entry right from the GIT mucosa, and therefore the gamma delta T cells, they also become a part of innate immune system, not a part of adaptive immune system. So if they are going to ask you, they'll ask you only about this one, gamma delta T cells. Okay. Acha. Now suppose you are given a B lymphocyte, or supposedly you are given B2 lymphocytes. So do you have any idea what is a B2 lymphocytes? Dekho, what happens is, whenever there is an activation of immune cells, whenever there's activation of an immune cell, so how does a B cell activate? समझो बात को. This again is important. Suppose there's a B cell. So on the B cell, the moment there is an antigen activation, the B cell becomes a plasma cell, and the plasma cell makes antibody. Clear है ये तो? अच्छा. But this antibody initially is not very specific. Even though B cell will always make a memory B cell, but very importantly, B cells also want a specific antibody against that antigen. So after some time, because of, please listen to me carefully, because of something called as somatic hypermutation. क्या होता है बच्चे? Something called as somatic hypermutation, the B cell will change to what is called as B2 lymphocyte. क्या होता है? B2 lymphocyte, and this lymphocyte makes specific antibody. ठीक है? Last year in INICET, the question was asked, the somatic hypertension occurs in which area? Answer is germinal center, GC. Answer is germinal center, GC. ठीक है. Lastly, the B cell. Lastly, the B cell will also class switch. Okay. The class switching के लिए, the class switching, it requires CD40 ligand of the T cells to activate CD40 of the B cells, and then it starts making the other antibodies, because the first antibody is always IgM antibody, right? But how will the other antibodies come? That is IgG, A, D, or E. How will this come? It will come only via the class switching, that is the CD40 ligand activating, CD40 ligand of T cells activating a CD40 of the B cells to do class switching. तो यहाँ पर the question important is what is a B2 lymphocyte? ये question आया था in the last year's INICET. This is very very important. ध्यान रखना this one. And where does it occur? It occurs in the GC area of the lymph node. Okay, lymph node. Gamma delta T cells not required, does not need B cell for activation. No, gamma delta T cell is always active and is present in the GIT mucosa. It is always active. ठीक है, it's always active. T-Rex cell are part of innate adaptive. T-Rex cell is a part of adaptive immune system, not a part of innate immune system. ठीक है, चलो. I think this answer I'll explain to you. It's a taurodine blue stain. So if it's taurodine blue stain, so what does it stain? It stains a mast cell. Okay, it stains a mast cell. Okay. MHC1 presents antigen to which of the following? So I think now it is easy now, because we already discussed this topic. So MHC1 is for rule of 8. Yeah, then CD8 cells. And what is CD8 cells? Cytotoxic T cells. Cytotoxic T cells is CD8 cells. ठीक है, चलो. अच्छा, what is affinity maturation? देखो, this one is affinity maturation. Very good question. This same step यहाँ लिखा ना, this one, the same step is called as affinity maturation. Affinity maturation. Very good question. In fact, these are the question of INICET. They are very very important. Immune system से you'll always get very very huge amount of questions. Please revise my notes of immune system very carefully for INICET. INICET से हम कम से कम पढ़ें 25 questions. It can make you or break you in INICET. Pathology is very very important for obviously NEET, but INICET is very especially important. Okay. The following banding technique is used for dicentric chromosome. अब समझो को banding technique. In the banding technique, depending on the stains, it can be GIMSA. Okay, so it is called as G banding. The often main use for GIMSA staining is actually for the AT rich areas. Okay, AT rich areas is stained darker. If it is reverse GIMSA, so reverse GIMSA means you heat the chromosome and you again put the GIMSA, and hence called as R banding. In this, it is often stained the CG rich areas. This area stained darker. Okay. For the chemical stains, it is called as C banding, and this stains the centromere. Okay, centromere, and the stain is called as a fluorescent stain. Is also fluorescent staining. Okay, and that is for Y chromosome. Okay, Y chromosome. So which stain do we use for Y chromosome? Is a fluorescent stain. That's a hint. Which stain do we use for fluorescent staining of the Y chromosome? Do you remember? Which staining for fluorescent staining for Y chromosome specially? Y chromosome specially. Bolo. Anyone? For Y chromosome, it's a fluorescent staining. Which one? So because in this question it is a dicentric chromosome, centromere, there's two centromeres, and hence the answer is there is C banding. Yes, the Q banding, the quinacrine. Okay, the quinacrine, the Q banding is for the Y chromosome. Fuelgen नहीं, not for fuelgen. Fuelgen is for DNA only. The fuelgen is for DNA, entire DNA. Okay. Fuelgen is for entire DNA. Okay. Not for the Y chromosome. Y chromosome is quinacridine stain. So quinacridine stain, that's a Q banding. Okay. Q banding. Okay. Chalo. So this is the use, and try to remember this one also. Try to remember this one also. Okay. Differential expression of a gene depending upon the parent of origin. बताओ क्या होगा? Parent of origin. What is it? Yes, the answer is genomic imprinting. अब समझो बात को. What is mosaicism? Mosaicism मतलब more than 2 sets of chromosome in same patient. From how many zygote? From one zygote. ठीक है? If I copy the same statement and then I write from 2 zygote, it becomes what? It becomes chimerism. तो 1 से नहीं, from 2 zygote. Okay? Not from 1 but from 2 zygote. It becomes chimerism. ठीक है? अब देखो what is anticipation. Sometimes what happens, as the generation is going one to next, first generation, second generation, third generation, after every generation the risk of disease increases, or if the disease is already there, the severity increases. It is called as anticipation. So increased risk oblique severity in successive generation, it is called as anticipation. So do you know where does this occur? This anticipation occurs in trinucleotide repeats. कहाँ होता है बच्चे? Trinucleotide repeats. ठीक है, अब आते हैं imprinting में. What is imprinting? समझो बात को. Imprinting मतलब if suppose there is a paternal gene and suppose maternal gene. ठीक है? Now paternal maternal gene both will have some or the other alleles, right? This, right? Now let's assume from the paternal side, father chromosome, the gene is expressing, but from mother chromosome, this gene has been silenced. So what is happening? It will not express. So in this case, even though the genes from the father is expressing, the mother one is not expressing. This is called as genomic imprinting. Okay. So what happens if you see now the deletion of the expressing allele? समझो बात को. If you see a deletion of the expressing allele, then the disease can occur. For example, I hope you all have heard about the Prader-Willi syndrome and Angelman syndrome. When we talk about the Prader-Willi syndrome, when we talk about the Prader-Willi syndrome, okay, so what happens? There is two syndrome here. One is Angelman syndrome and one is Prader-Willi syndrome. So if you get a deletion oblique imprinting, okay, imprinting of maternal chromosome, it is Angelman syndrome. And if you get a deletion imprinting of paternal chromosome, it is called as Prader-Willi syndrome. How to remember? P से P याद कर लो और M से M याद कर लो. That's it. Simple. Okay, that's how you can make the entire thing simple. And where does it happen? It happens on chromosome number 15. But this is only for deletion imprinting. Suppose the question is on disomy. मान लो, if the question is on disomy, so if it is paternal disomy or it is suppose maternal disomy, then the thing will become reverse. Here, do not use the mnemonic P for P or M for M, because paternal disomy is Angelman syndrome and maternal disomy is Prader-Willi syndrome. So how to remember? इतना याद ही मत करो ना. Why to make it so tough? Make it simple for yourself. I will use the mnemonic P for P and M for M if the question is on deletion or disomy. Sorry, deletion or imprinting. And if the question disomy, I won't use the mnemonic. अरे mnemonic use करो अगर deletion है या imprinting है. Don't use it if there's disomy. क्या मुश्किल हो गया? ठीक है? P for P, M for M. So simple. So simple, है ना? चलो. What is the technique being shown here? बताओ. What is the technique? Sanger technique क्या होता है बच्चे? It is for sequencing. Very good. It's for sequencing. But remember, this is the old technique. The new technique for sequencing is next gen sequencing. Next gen sequencing. Okay, next gen sequencing. ठीक है? What is this? Yes, it is fish. It is fish. It is fish. Okay. So what is karyotyping? In karyotyping, you have to just look at the chromosome. Karyotyping के ऊपर भी images, as I show the images, and PCR obviously is polymerase chain reaction. Polymerase chain reaction is PCR. Okay. So what is the basic idea of fish that is important to understand? So suppose you take a probe. Okay. क्या probe क्या है? Suppose a DNA here. ये DNA है. ठीक है? ये DNA है. Okay. Now in the DNA, suppose the sequence of this part sequence is A T C G. ठीक है, ये एक है. Now I am taking a probe here. ये probe है. ठीक है, तो probe will have an alternate and opposite sequence. मतलब for A T होगा, for T A होगा, for C G होगा, and for G C होगा. This becomes a probe. The moment I add a fluorescent color on this, it becomes a fluorescent labeled probes. It becomes what? It becomes a fluorescent labeled probe. ठीक है. Now what I can do is I can put this typical probe. Okay, I can take the probe and I can add on DNA. Agar the probe is joining this, it means there is no mutation. But suppose, example, I made this probe and let's assume that there is any mutation here and this has changed from the normal C to T. So this probe here won't bind here. If the probe cannot bind, something is wrong, right? That is what is the basic idea of a fish. Okay, so fish can look for any chromosomal alteration in terms of number or in terms of structure. Numerical and structural mutations can be seen with fish. Okay, with fish. This is a fluorescent label probe. Look at red color probe. दिख रहा है red color दिख रहा है ना? This one is red color probe. ठीक है, ये क्या है? ग्रीन कलर का प्रोब है. रेड है और ग्रीन है. अब समझो, suppose I have taken one probe of red and one of green, and what I am seeing is supposedly a yellow color. You have to tell me, suppose I see a yellow color here, but I have put what? I have put red and green, but I am seeing yellow. What does it mean? Anyone? What does it mean? Bolo. If I am seeing red and I am seeing green, okay, separately, तब तो अलग बात है. But suppose both of them come together and make a probe whose color is yellow. It means both the chromosomes have come together, and therefore this signifies what? It signifies translocation of the chromosome. It signifies translocation of a chromosome. Fish is a very very important technique. इसको पढ़ लेना. And what is the basic limitation of fish? Fish can be used. Remember, the fish can be used only for known genetic locus testing. Okay, fish is used only for known genetic locus testing. You cannot apply fish if the area of mutation is unknown. ये ध्यान रखना. Okay, चलो. The following are AIDS defining malignancy. The following are AIDS defining malignancy. The following are AIDS defining malignancy. बोलो. Except. Answer फटाफट. All of you waiting. Yes, देखो. Remember the AIDS defining malignancy क्या क्या होते हैं. पहले देखो what is the AIDS defining illness. This HIV is very important. I think I should not tell you how important HIV is. HIV, STD, TB. There is no alteration of reading this. देखो, for the neoplasm, Kaposi sarcoma, primary lymphoma of the brain, and invasive cancer of cervix. These three are the AIDS defining illness. ठीक है, वापस समझो. The AIDS defining illness are Kaposi sarcoma, ठीक है, primary lymphoma of the brain, and invasive cancer of uterine cervix. Okay, so Kaposi, it's a AIDS defining illness, ठीक है, primary lymphoma of the brain and the invasive carcinoma of the cervix. But melanoma is not a AIDS defining illness. Okay. Apart from this, in virus, CMV, herpes simplex, varicella zoster, and PML, they also are viral AIDS defining illness. Okay. In bacteria, MTB, nocardia, and salmonella are AIDS defining illness. Okay. In fungus, Candida, crypto, coccidiosis, and the histoplasma is again AIDS defining illness. In protozoans, cryptosporidium, pneumocystis cerevisiae, okay, and toxoplasma. In pneumonia or sinus infection, these again are the AIDS defining illness. So AIDS defining opportunistic infections and neoplasm found in patient with HIV infection. This is very very important. इसको ठीक से पढ़ लेना. AIDS is important. This is must and must to know, or at least know what are the criterias. There is helminth, fungal, bacterial, viral, and neoplasms. These are the AIDS defining illness. ठीक है, चलो. A female presented with fertility, dyspnea on exertion. She was found to having hemoglobin of 6, most likely PS finding. अब देखो, the most common cause of anemia is being asked in a different way. This question have been asked as the most common anemia in an adolescent female is. The answer would have been same, iron deficiency anemia. The answer is microcytic and hypogrammic RBCs, because this most common anemia in India is iron deficiency anemia. The simple way of asking this question would have been most common anemia in adolescent female. Answer would have been same. Yeah, the most common tumor in HIV infection is diffuse large B-cell lymphoma, DLBCL, the non-Hodgkin lymphoma variety, followed by Kaposi sarcoma. Okay. The following is correct regarding lab findings of anemia of chronic disease. बताओ, देखो, a simple way to differentiate these as, पहले ऐसे समझो, iron deficiency anemia, ठीक है, IDA, ACD, and sideroblastic anemia. What do we need to differentiate? Serum iron, serum ferritin, ठीक है, TIBC, and percentage transferrin saturation. ठीक है, अब समझो बात को. First of all, you need to understand that two things will always go opposite. This one and this one go opposite, and this one and this one will always go opposite. ठीक है, these two and these two will always go in opposite direction. Always go in opposite direction. कैसे देखो? In case of IDA, low iron and low saturation. In IDA, what should happen to ferritin? Low. And because I told you ferritin and TIBC should go opposite, so TIBC should be high. ठीक है, अब समझो बात को. In case of ACD also, low iron and low saturation. Low iron and low saturation. But opposite happen in ACD, high and low. ठीक? And then I told you this one and this one go opposite. कैसे? In IDA, low iron, low ferritin, high TIBC. Exactly opposite here. मतलब high iron, high ferritin, low TIBC. And saturation is also on the higher side. Because I told you this one and this one go opposite. Simple ऐसे. तो इसको ऐसे याद करो. ठीक है? These two go opposite and these two go opposite here. ठीक है? And based on this, let's try to focus on this question. क्या पूछा हुआ यहाँ पर? So correct for ACD. So बताओ, ACD में ferritin is high? Yes. So it is false here. Reduced hepcidin level? No, it should be high hepcidin levels. This again becomes false. Saturation is low. Yes, that's true. And TIBC is increased. No, that is also false. It is low. The answer क्या होगा? C is the answer. Okay, C is the answer. Transferrin saturation is decreased. Yes, it is decreased. And not D. TIBC is not increased here. It is decreased there. Hi everyone. Yeah, this is a um, ground shaking INICT session. We can just make fun out of it. But yes, really, I had to run out of the studio, and it was very scary. But this entire part was very scary. I just came back to tell you all a goodbye, and I don't know what to do. So anyway, the question was almost also over, and so I think we should only discuss as to what we're all doing when this entire thing happened. I can see the 158 of you still live here, waiting for me even after earthquake, and really feel amazing out of it. I cannot say thank you, but हाँ मैं ठीक हूँ. In fact, the entire entire community came down out of the house in the open spaces, unsure of what will happen. And these things actually tell us that how unpredictable the life can be. It tells you that is what I also realize, that anything can happen, right? There's no prediction. The life was very unpredictable, but really, I even cannot say thank you for staying here, because it was a really, really very scary earthquake. I cannot even imagine, and I cannot even describe the way that the entire thing was shaking. The lights here was about almost to fall on me. When I just ran from here, the big lights here, they were almost about to fall on me, and everyone was like shouting outside, and I realized that um, that a lot of things are very, very highly important than life, than anything else, and life is the most important thing. आज रात आई थिंक रियली बाहर ही सोना पड़ेगा. यस श्योरली जीतू मीना, आई थिंक दैट्स वेरी इंपॉर्टेंट थिंग टू से. हाँ यार. uh, तो आई वाज and the Richter scale actually saying 7.4 in from Afghanistan is also very, very scary there. The 7.4 is really a very huge and very dangerous type of Richter scale. And in Delhi it was around 5.5 plus. So I can tell you what the numbers is different, but the way the things were all shaking, and it really changes. It really pumps your heart. And those who are in Delhi, I really pray to God that you are all safe everywhere with your family and relatives. You are all safe everywhere. But this was completely unexpected. Even though my questions discussion was over, I'll share this PDF in some time in my own Telegram group. Yes, I'm very safe and sound right now, and the earthquake was right from it originated from Afghanistan, they say, and from Pakistan actually was the seismic wave went to Uttarakhand, right from Rajasthan, Delhi, and Uttarakhand. Half of them was completely shaking, and I really wish all of you to be safe there. मुझे कैसा फील हुआ, I don't know what to say. I just really ran away from all the things, and can't even describe right now how my heart is feeling. I was really unsafe of what we were doing. So anyhow, my question discussion is over. I just pray to God that wherever you are, just stay safe and just stay cool and happy. May God bless you all. So take care is what I can just tell you. The question discussion is was almost over from my side. A few questions were there, but I'll just not you know share those questions. And thank you for praying with me for me. But honestly speaking, it's very scary session for me too. So thank you guys. Good night to all of you. Life is really very fickle, and I think we should all be very fortunate that life God has really given us a good life. And these realizations come only when we have such dangerous moment like as I we had this now in Delhi. Um, I cannot even describe the feeling that I was having when I was running out of the studio. Um, and I was very much also very afraid and very frightened as to what will happen. A lot of things in that case. So no, I won't be continuing the session right now. I just wanted to come back and say you all goodbye because I could see that around 170 students were waiting for me, and so I really wanted to come back and tell you a very good night and goodbye to you. So this session is done, and I'll share the PDF with you. Not now. I'll just take some time to do that, and yes, I'll say that. Okay. So take care, goodbye. And it was a life experience for me taking this session for you. I I cannot say more than that. Um, so take care. God bless you all. Goodbye. Good night also.